Good evening, everyone. Welcome and thank you for joining us today for our case observation webinar. During this event, you will observe a pre-recorded primary total hip replacement surgery and ask questions to an amazing surgeon PA team, Dr. Barrett and Jana Flenner. They will share their tips and tricks with us and why they work so well together. My name is Sandy Youssef, and I'm the National Manager of Professional Education here at Ethicon. We are so excited that we can offer you this virtual experience. Due to the fantastic technology being used in the room, you will actually feel like you are right by the bedside. Please note that we want this to be an interactive experience, and we'll answer all of your questions at the end of the case observation video. In order to ask a question, please use the Q&A box at the bottom of your screen to submit your questions. Dr. Barrett and Jana, I will turn it over to you.
Thank you so much, Sandy. This is always exciting to do these webinars with you. So first of all, thank you so much. I mean, you have been absolutely inspirational, and I really do want to give a shout out because even during COVID, Ethicon refused to be grounded. And you guys just thought of new ways to innovate and get out education to PAs and others who wanted to join through a lot of mentorship programs. So kudos to you guys and all the hard work. So we're really excited to be part of this process. And thank you, Dr. Barrett, for joining me today as we talk about direct anterior hips as well as what it takes to make a good wound closure.
Well, Jana, thanks very much. And I think the first note would be, you got to call me Bill instead of Dr. Barrett. Going to make me feel like I'm my grandfather. So, yeah, I want to second Sandy what Jana said. It's just an absolute pleasure to do this. It's fun, and you guys have really been at the vanguard of leading PA and surgeon education. So we really appreciate that opportunity. And Jana, thanks for getting this stuff organized and all dialed in.
Yeah, so we're ready to dive right in, and we'll get started with our x-ray, and we want to talk about our patient. And so just briefly, so this is a 56-year-old male that we're going to be speaking of, and here we have an AP pelvis, and this is generally the view that we get for multiple reasons.
Yeah, Jana, why don't you talk about it? I mean, AP pelvises can mean different things to different people. I mean, you want to get a front view of the pelvis, but usually we like to see the very lower aspect of the lumbar spine and be able to see enough of the femur that if there's something downstream of where the stem may be, we find that. And so this shot basically from more or less the top of the iliac crest down to the middle third of the femur is quite useful. And why don't you describe for folks what you look at when you see an x-ray like this? Somebody comes to you, they go, man, my both hips hurt, my right hip hurts more than my left.
Mm-hmm. Yeah, I mean, that's a great question. So what we use in our clinic anyway is the Kellgren-Lawrence rating system. And the reason why this is good for us is that when I come up and communicate to you about a patient and we don't have an x-ray available, you know exactly what I'm talking about. So the rating system goes from 0 to 4, 0 being absolutely no arthritis seen, whereas Kellgren-Lawrence 4 is what we see here, and that is bone-on-bone articulation, definite joint space loss. We've got osteophyte formation, and we may even start seeing some deformity of the femoral head or the acetabulum.
And I think this is also, like you mentioned, a communication tool and allows us to describe not only to colleagues, but to insurance companies, because certainly in the state of Washington, there's a BRE criterion. If you don't have at least Kellgren-Lawrence 4 changes, you've got to jump through a lot of hoops before they'll authorize surgery. So the fact that we have a reliable, relatable rating system, I think, makes this a very useful classification term. So you mentioned joint space loss and really no cartilage left, a little flattening. Maybe if we look at the lateral view, we can see it. Does that confirm what we saw in this AP view? So if we can advance to that lateral x-ray, there we go.
Yeah, and again, we see here that this is definitely bone on bone. You can also see the osteophyte formation down there in the inferior portion around the head neck junction of the femur.
And what's that dark circle you see just above the socket? It looks like a subchondral cyst formation right out there. No, I wasn't talking about bowel gas.
Yeah. Where are we going?
That's a trick question.
Yeah.
Yeah, I think they're constipated.
Yes.
No, but that
Yes.
cyst formation, right, kind of just inboard of the lateral aspect of the acetabulum.
Right, and those are actually very normal changes that you'll see in the arthritic patient. And when I'm explaining this to a patient, I literally explain it like you got a brand new pair of shoes and it's rubbing just the wrong way on the back of your heel, and you end up getting a blister on the back of your heel. So very similarly, as you lose the cartilage articulation surface, and you've got bone on bone, and the cystic changes are not unusual to see.
And how many times have you had a patient whose primary care doctor ordered an MRI and they come and they go, my doctor told me I have a huge cyst in my bone?
Yeah, a lot. Actually.
Yeah, and so I kind of like that. I've never used that blister on my heel, but I like that analogy. So, okay, we get these x-rays, and let's assume that all other things line up and this patient's going to get scheduled for surgery down the road. Do we just go in the operating room and kind of hold up a thumb and go, yeah, I don't know, that might be pretty good? Or do we do some planning before surgery?
Yeah, we absolutely do a lot of planning, actually. So we use our AP pelvis, and from that we do our templating, because what we want to make sure we know and understand is the leg length discrepancy, as well as the offset. So offset meaning the distance between the symphysis pubis and the femoral shaft itself. So we want to make sure that we recreate both of those for those patients, because that is like the number 2 reason for litigation after a total hip replacement is leg length discrepancy.
And while many of my colleagues from the podium will talk about how they template their x-rays, if the truth be told, how often do I template x-rays?
0.
Would it maybe be 0? And so the templating in our office and in many offices is done either by a PA or sometimes a rep. And so why don't you, if we go to the next x-ray, why don't you walk us through your thought process when you template?
Yeah, the first thing that we do is we want to make sure that we understand the leg length discrepancy. And we can do that where we draw, you can see the yellow line there at the symphysis pubis, and that's kind of our leveling plane. Another common area, and maybe a more reliable plane, is off of the teardrops. And you'll see the teardrops up there just at the bottom of the acetabular region. And that is a more reliable source of getting your leg lengths. But once you discover what your leg length discrepancy is, then you can start laying in your template, and that will help you with sizing, as well as when we make up for that leg length discrepancy where we place the femoral component, helps you know and understand where to make the femoral cut when you're getting ready to do the osteotomy there.
And the other thing is socket size. I mean, is that just a guess, or do you figure, well, okay, we're going to ream a little bit. We know we're going to take 1 millimeter or 2 of subchondral bone away. How do you decide where to put the socket?
So I try to put the socket close to the medial wall, which you can see represented there by the teardrop, but I don't want it up against that. So I want to leave 1 millimeter or 2 of a space there of bone in the acetabulum. I usually make my socket template just over the top of that subchondral bone there, and that usually represents 1 to 2 millimeters of subchondral bone that will ream away at the time of surgery.
And so once you do your socket, then you can lay in the femoral component, adjusting for the leg length difference that you've ascertained from that transverse line that goes across the ischium that you then check with the anatomic teardrop. So from that, you figure out length, socket size, stem size. Yeah. And, you know, in the past, it maybe didn't matter that much because we got a room full of implants. Right. But as we'll talk about later, a lot of these procedures are being done now in an outpatient facility. So we don't have like a warehouse attached to the hospital where we can pick every implant. So it really does have impact as far as the implant inventory. So, all right, you get this all ready. We kind of know what our plan is. It's much like the architect developing the plan for the builder, you being the architect, me being the builder, but then we both work together. So the patient is kind of getting in the queue. Are there things that you'll do as far as trying to optimize these patients and make sure that they're really ready for surgery, just not physically ready for surgery?
Yes, absolutely. You know, it is super important, particularly as this is an elective procedure, that we make sure that we have modified all the modifiable risk factors so that we can help this patient get through a very successful journey of a total joint replacement. And so we take them through a whole optimization process, and we try to address at least what we consider the top 5 modifiable risk factors.
Why don't you talk about those? I mean, because people hear this modifiable risk factors. I mean, there's a lot of risk factors. Some of them, I mean, if I have heart disease and I've had a 5-way bypass, I mean, I can't modify, I have heart disease, but why don't you talk about some of the things that are modifiable?
Yeah, so our top 5 would be diabetes, obesity, smoking. Malnutrition actually is really high and pretty predictable at poor outcomes. And then while rheumatoid arthritis is not necessarily modifiable, there are a lot of things that we can do now to actually get them really well prepared to go into the operation.
So as far as diabetes, is there a number? Do you just go take care of your diabetes? Or, I mean, what is it that you look for?
Yeah, so data reflects that diabetes, what we want to do is try to get our hemoglobin A1C under 8, because those that climb above 8, so goes the linear curve of infection, deep joint infections, wound-related issues, surgical site infections, that sort of thing. And we also know, just part of the healing process of the wound, that diabetes really does interfere with not only the inflammatory response that is needed after surgery, but also the proliferative state where we're laying down collagen.
So smoking, is it just because you don't like smokers, or is there a reason why this is an issue? Or maybe
Right.
they just smoke when they drink, or I mean, what's the story with that?
Yeah, I mean, smoking, a lot like obesity, this is a very emotional conversation. And I really do try and share with the patient that it's not right or wrong. Smoking's not right or wrong, neither is obesity right or wrong. It is just a risk factor that we have to modify. So we know clearly through data, and doing meta-analysis, we can see it, that smoking in particular causes vasoconstriction. So that inhibits our normal inflammatory response that we need to mount after a surgical procedure. It decreases our collagen production. So the reason why that's important to know is that when we pick a suture, what we're asking that suture to do is to stabilize the wound until our bodies can make the link of the collagen to stabilize it and then go on to healing. But if they can't mount the inflammatory response, and if they can't lay down collagen, they will never be able to heal their wound. So when those sutures break down at an appropriate time, their body has not given them the structure to heal their wound. So that's on us for not modifying that patient. That's not a suture issue.
What about obesity? I mean, obviously it's harder to operate on a very large patient just because the actual activity is like elbow deep inside the body. But other than that, are there reasons why that, other than just we don't like to operate in that deep a hole, that obesity really makes a difference?
Yeah, so the obese patient is in a chronically inflamed condition. So again, when we start talking about mounting these robust inflammatory responses when it comes time for surgery, they're basically incapable of doing that, because literally, as I see the inflammation part of it, it's like clean up on aisle 5. If you've got all of your people who are designated to clean up aisle 5s chronically working, then when it comes time to mount this important inflammatory state, there aren't enough worker bees, so to speak, to make that response. So that's number one important. And 2, again, it's the collagen production. And they're just this, go ahead, I didn't interrupt.
No. So what I'm hearing you say is that with all these things, diabetes, it affects your, immune response, smoking, vasoconstriction, obesity, same thing, chronic state of inflammation. And so all of these things, and obviously malnutrition, they're not able to muster the same type of resources from a physical standpoint as somebody who's not malnourished. And, same thing with rheumatoid arthritis or some type of inflammatory arthritis. While there are medications now that are disease modifying, and clearly the reason they're disease modifying is because they modify the immune response. And so let's say I have RA, or, you see all those commercials on TV, I've got psoriasis and I don't want to show my elbow. Is it important that those medications get stopped ahead of time, or can you just keep taking them right up until the time of surgery?
No, I mean, there is appropriate timing for each one of those medications to stop and then to hold it for a certain amount of time after the operated procedure as well, because what we don't want to do during this time is to suppress their immune system. We really do need that robust response. And we've been able to come up with a pretty simple rule on how to determine when to stop and start it.
And that is, why don't you just review that? Because it is pretty simple.
Yeah, so
they're all on different cycles, right?
That's right. So let's just say you're on a medication that you dose once a month. So basically the recommendation is that you should hold it 1 month plus 1 week prior to surgery. So that would be 5 weeks. And then you want to wait 1 month and 1 week before you start again after surgery.
Okay, well, that makes sense.
Yeah.
And actually, isn't there a recommendation that was published by the American Hip and Knee Surgeon Society and the rheumatologists, is in like Journal of Arthroplasty somewhere?
It is in the Journal of Arthroplasty, and Dr. Brian Springer and Dr. Goodman did a really great job of putting that together.
So basically it's a table that tells you. You can refer to that, so you don't have to remember what we said tonight on this webinar.
That's right.
All right, so we've gotten the patient templated, we've gotten the patient optimized, we've changed their modifiable risk factors. And then the question always becomes, how do we get to the hip? Do we go through the front? Do we go through the back? It sounds almost like a bank robbery, but what are some of the reasons why you would go one way or another? And does it make a difference?
That's a fantastic question, and I think this has been debated back and forth for quite a while now. I have to honestly say, whether you do a direct anterior approach or a posterior lateral approach, I think there's still great operations. But I think that we have found in our practice, and I think it's becoming more and more evident as time goes by and data is collected, that the anterior approach does seem to have a quicker rehab time.
Yeah, it's something we found. I mean, you painfully experienced with me when I transitioned from posterior approach to anterior approach almost 15 years ago, and it certainly added to the surgical time.
Right.
I sweated a whole lot more than I used to. But eventually we got through that learning curve that's somewhere between 20 and 50 cases, depending on the surgeon, the circumstance. Right. And we've actually published a couple papers in the Journal of Arthroplasty on this, the fact that during the first 3 months, there's less pain, quicker recovery, quicker return to activity, and no difference in complication rate. But in fact, when you look at those patients at 1 year, there's really no difference between an anterior and posterior approach. So like you said, they're both great operations. We do all of ours now through an anterior approach just because of that advantage to the patient of a faster healing, faster recovery, less pain. But again, well done total hip's a well done total hip. So what we're going to talk about today is we're going to walk through an anterior approach total hip. And thanks to the great video that you were able to acquire during surgery, we can walk through that. So why don't we roll to the operation? And this is a right hip replacement. So the head is to the left, the foot is to the right. We're making an incision right over the tensor muscle, and it's anywhere from 10 to 12 centimeters in length. I think I made it a little bit longer so we could see better. And the beauty of an anterior approach is that the hip doesn't have a lot of tissue over the front of it. So you go through the sub-Q and you're quickly right on the fascia of the tensor fascia lata muscle. You can see it twitch a little bit there, and it's sort of this gristly blue structure. And we simply open that fascia with a blade, being careful not to damage the underlying muscle. And then it's a finger dissection. We grab hold of that with an Alice clamp after we mark it for later closure to ease somebody's job.
Yes.
So here we are with an Alice clamp, and we're going to free the muscle literally with our finger from the fascia, and it separates quite nicely, and that allows us to get into the interval between the anterior femoral neck and the greater trochanter. And my finger's right over the lateral trochanter there. We put a cobra retractor over the lateral femoral neck. And then there's a vessel, the lateral circumflex, that always crosses through the field. So we find that, identify it, and coagulate it. And then we can cut through that area. There's often a second branch. That's what I'm looking for there, so we don't get squirted. And so once we get control of these circumflex vessels, it's pretty much freeway time.
And that used to be pretty easy before we recognized that those were there.
Yeah, well, you recognize they're there because if you don't get them ahead of time, then all of a sudden you look like the backseat of Pulp Fiction.
That's true.
So, I'm simply splitting the fascia on the floor of the tensor compartment. It doesn't really have a name. We just call it Janus fascia. And so we take a second retractor and we're retracting the tissue off the anterior femoral neck, and we'll place another cobra. So literally by simply finger dissecting the tensor out of the way, we're right on the anterior femoral neck. And this is kind of an optional third retractor we'll put to elevate the reflected head of the rectus out of the way off the anterior capsule. And so we use this small bent Homan, and literally we're right on top of the hip joint. And that takes generally just a couple of minutes to be right there. And there's been no muscle transected. We're going to open the capsule, and there's a variety of ways of doing this. We tend to make almost an I, capital I. We go vertically, then along the base of the neck and along the rim of the acetabulum. This has been described in a variety of different ways. We save the capsule, as you know. Others will absolutely just excise it, and it doesn't seem to make a huge difference. We like to replicate anatomy. So we place a tag suture in the capsule, and once we do that, we're going to place the retractor deep to the capsule, so it'll be literally right on the femoral neck. And there's one retractor under the capsule. And then you and I do this together, standing on the same side. You have a better shot at this from being at the head side of me. And so you'll release that inferior retractor. Now we're placing a corkscrew in the femoral neck. We're going to make our femoral neck osteotomy. So we're going to cut the head in situ. We don't dislocate it ahead of time, but according to our template, we know what level to make this cut at. And so once we make the cut, we're able to free that up and disimpact the head from the neck. We'll attach a T-handle to the corkscrew and lever the head out of the acetabulum. Now, some prefer to dislocate the hip first, relocate it, then make the cut. Others will take a napkin cut type of napkin ring out of the femoral neck. We don't do this. We put it in, rock it back and forth, protecting the tensor, and usually we can have a delivery of the femoral head. It's a boy. Here it comes. And so there's the femoral head with the ligamentum teres torn and showing the arthritis, the cut femoral neck. And so now we take those same two retractors, one posteriorly, one anteriorly, and we have excellent exposure of the socket. And using an angled reamer, we have great access to the socket. Usually we start a couple millimeters smaller than the measured head size. So in this case, perhaps the head measured 50. We'll start with a 48 reamer, ream 50, 52, maybe it'll be a 54 socket. And we check this. The beauty of this is we can check this under C-arm, and you run the C-arm while I'm reaming. So you bring the C-arm in, show me the image of the reamer in place. Once we get to our final reamer that gives us circumferential reaming of the socket, and I'm checking the thickness of the anterior and posterior wall. So our thumb and index finger is in many ways like a caliper of where we want to stop. We know roughly within a size or so of where we're going to go from your pre-op templating. Mm-hmm. And so that really guides our reaming process. We can also check it with C-arm. And then there's Vanna White. There's the socket, and it's a porous coated socket. We use a concise impaction device. So we place this roughly to begin with this angled handle. We attach the concise, which is an impaction device, and that delivers 6 blows per second of the same force and allow us to seat the socket. Once it's seated, we disconnect it. We check with an image and our software program to confirm. We shoot for 43.23 plus or minus 3. We're 44.21. That's acceptable. So we're going to place our real liner, and we always used a non-lipped liner because we're confident of the placement because of our X-ray, and B, our software program. So we know exactly where that cup is, so we don't need lipped or offset or different liners. We check to make sure it's completely seated. And then we're going to turn our attention to the femur. So we place a hook around the proximal femur, lower the leg to the floor, and that hook allows us to elevate it. And basically, as you've seen ad nauseum, we release basically an index finger's amount of soft tissue from inside the greater trochanter, the conjoined tendon. And once we do that and release the lateral capsule, the femur will elevate up out of the incision. The hook isn't really like a jack. You jack your car up. It just allows us to realize the release that we've done. And now we can sound the canal. And so we use this box osteotome to open the femoral canal and remove a small amount of bone. Now, the device we're going to use relies on a compaction broaching system. Sometimes the hemostat falls in the way of the camera.
So we're using a Hanna table while we're doing all this.
We are, and I'm sounding the canal now, and the Hanna table does specifically have a spar that drops the leg and has a hook.
Right. Makes life a lot easier for assistants.
For us, but you don't need the Hanna table.
True.
You can do this on a regular OR table with appropriate modifications. So this isn't just the only way to do it. There's a lot of ways to skin the cat. Mm-hmm. So here's our first broach going down. It's smaller than we anticipate by a couple of sizes. And this basically allows us to get down the canal and find our way. We typically do this by hand, just because I like the control of feeling how it's going to make sure I'm going down the center of the canal. And then once we do that and are confident all is well, we'll go to our compaction device, which really speeds up the operation and also takes a lot of stress off the surgeon. You're not swinging that being a fancy carpenter.
And you were using the suction device there to make sure that you had not perforated.
Exactly. There was actually an article you and I saw that if you put the suction device and it goes down the canal and sounds like it's slurping, you're in the canal. If you put it down and it just goes quiet, that means you perforated the femur and it's stuck in soft tissue. So now we're sequentially going up, and with Concise, you can see us there in the inset. I'm literally just pulling a trigger and it's banging it down into the canal. We get to a size where we think we're going to stop, or maybe one short. We do a Calcar Miller. We're going to do a trial reduction, get rid of the bone chips to minimize the risk of heterotopic ossification, drop our trial neck on our brooch, which acts as a trial stem, attach the head. This looks pretty easy. Sometimes you and I know we struggle to get that in tight, soft tissue.
Right, particularly in high offset.
High offset people and people with wide hips. And so we bring the C-arm in, and then what we're going to do is look at our template, have an idea of what we wanted to do based on our template, and see how close we are to that with our intraoperative x-rays. So now we haven't bought a stem, neck, or head. We have the cup, but we're confident with that position. So now we take our real implant.
And based off of what we saw on Bellis, joint point there, we discovered that a high offset was actually better for this patient.
Right, because you had templated, and you and I both thought it was going to be standard, but
right.
Based on the information from the software, the Bellis hip navigation, we switched intraoperatively to a high offset, which more appropriately restored the length and offset. And this is pretty typical. This is the active stem, usually seats to about here with very little pressure. Now I can use the Concise tool with an impaction device. It drives it quickly right down, seats that till the collar is flush on the Calcar. Remove our little protective hula skirt, and then we're going to take our ceramic ball, which is pink, not because it's a female, but because it just is pink. It's a Delta ceramic. Attach that with slight rotation, seat that with one firm 4,000 Newton blow, and then we're going to reduce the hip, and based on our previous x-rays from the template and from the hip navigation, we should be correct, show proper demonstration of our circulating using her knees, not her back, to lift the leg up. Manual traction, and then applying some fine traction so that we can safely relocate the hip. The ball will kerplunk into the socket. We make sure that we don't catch the capsule between the ball and the socket. We put betadine for a soak, and now you're capsule with the micro tag suture that provides us a watertight closure of the capsule. And then now I'm basically going into non-thinking mode. So why don't you take over?
Yeah, so the next layer that we'll close after we trim off the suture is our fascial layer, which we'll use the #1 Stratifix. And the importance here is that you start your suture with the needle pointing toward the apex of your incision. So you want to get as high up as you possibly can. The key is that you don't rely on the tab. So the tab that you see here on the suture just holds the suture in place until you can throw 2 perpendicular throws over the top of that behind the tab to lock it. And you'll see that we're demonstrating that here. So we're going through the fascia. We'll go under the fascia on the opposite side, coming out underneath the suture, and then we'll do that twice. And again, we're going to lock that in place above the tab. And once we've secured that, then we can take off to the races.
So unlike some surgeons who view the tab as sort of like you throw an anchor off your boat and it just digs into the sea bottom, the tab isn't really an anchor. It's just simply to lock 2 throws over, which then locks the suture. So I think that's a really important point, because surgeons go, oh, I use this and it pulled out. Probably they're not using it correctly.
That's right. Yeah, generally speaking, when you look at these tissue control devices, such as the barbed suture, it has great tissue control. This particular suture is stamped out of the material, so the strength of it is actually superior than your Vicryl.
So I have to point out, we had to actually slow this down, because normally this is much faster than this, but we had to slow it to 1/2 speed because you're so quick at closing this.
Otherwise, there would have been smoke coming off that incision.
Yeah, the needle would have been burning.
That's right. But this is a pretty quick closure, and that's another thing that makes us more efficient in the operating room. While we have good tissue control, We get good approximation of the skin edges. You don't crank on the suture. I literally just take the force of my forceps to pull it tight, and that's all you need to get a watertight closure. At the end here, I'm just going back on myself 2 throws like a baseball stitch, again, to lock it. And when we're locking it like that, that is taking the place of knots in our suture, which knots in a suture can be a nidus for bacteria to harbor and start a surgical site infection. So it helps us, 1, get great tissue control, and 2, avoid those types of issues. From here, I'll go up a layer and we'll start closing Scarpa's fascia. So I'm just demonstrating here that baseball stitch locking.
It's like an instant replay slow-mo, I think, to catch that.
That's exactly right. But it's super important to know that you've got to lock this. So here you can see Scarpa's fascia. You'll see it in every hip sometime. It's a little more difficult to find it, but it is definitely there. Since we've been closing Scarpa's fascia, we have not had any type of seromas with our hips, and we actually have a great watertight wound closure. Yeah,
because early on we started doing anterior hips, we would have people come back, look like they had a speed bump under their incision. It was a seroma because you weren't closing that Scarpa's fascia. Actually, this has eliminated that. It just doesn't happen anymore. We don't use drains on our hips.
Right. Yeah, so as I near the end here of Scarpa's fascia, again, once I reach the apex, then I am going to come back 2 throws again to lock it. And then once you lock it, then it can just be cut flush with the fascial layer there.
And so that's it. You run down through the fascia, back up through Scarpa's, and then you cut that #1 Stratifix.
That's right.
And what's next?
So next I will actually use a 3/0 vicryl, and I used to use a lot more when I first started closing with a running suture. But what I've learned as we've tried to make our incisions smaller for patient satisfaction purposes, sometimes the very apexes of the suture or of the incisional line really does get quite stretched out, almost like a bad pair of underwear. So it's kind of hard to approximate it nicely. So if you put a little stay stitch here right at the very distal and proximal end, it makes that come together much nicer. So that's what we're doing here. And I use a 3/0 vicryl for this. And I'm putting in another at this end.
And so you're trying to make up for the fact that I made my incision a little bit shorter, and I use retractors to basically tear the skin at the proximal and distal end.
That's right. Yeah, you said it, not me. So now we're going to start with a 3/0, and this is a Stratix Spiral. So unlike the symmetric, this barb is actually etched into the suture, so you would not want to use this in a high wound tension closure like you would the #1 Stratifix symmetric. That you can definitely use, and is the only FDA approved suture to use in high tension wound closures. So here I've gone through the apex, come back on myself. I'm feeding that through a loop, so the loop takes the place of the knot. You know, once again, we've answered that question of trying to eliminate infections from starting with knots. This is a PDS, so we're avoiding a braided suture as well. And then you can just run this, you know, subcutaneously or subcutaneously, depending on whether you're closing a hip or a knee, but in this case, obviously we're doing a hip. And I just run this all the way down, and once I get here, then I finish up. And I try to make my last throw at the very apex of the wound. And once again, you've got to come back 2 throws in which to lock it.
And so, okay, you'll come back, go on the opposite side.
Right.
And how much overlap do you do from one side to the next? Is it 50%, 25%? How much overlap?
It's about 25% overlap in order to get that nice skin approximation and watertight closure. So I'm coming back on myself now to lock it. And then let's say I end on the edge of the skin that's closest to us. Then what I will do in order to ultimately end up cutting off the end of the sutures, I will take a deep dive into just the middle of the wound. So I've got one more stitch to throw here, it looks like. So now what you'll do is you'll literally go down through the middle of the incision and come out the skin. And what that does is it actually helps approximate, oh, it looks like I have one more throw to make there. I faked myself out. But literally you'll just come out the opposite end and up to the skin. And so that just brings that final throw, the skin edges nicely together.
Right.
And then you can just cut right at the skin level when you're locked.
So there's no knot at the end. It's just that reverse and then come through the skin.
That's right. So now we're ready for the final closure. So we will put down our Dermabond Perennial. So the nice thing about this is a flexible antimicrobial barrier that helps prevent infections by preventing any type of bugs that we're used to seeing in surgical site infections to even get near the wound. So we're laying down the mesh. We like to have it extend 1 centimeter above and below the incisional area. Then we put the Dermabond on. There's plenty of the Dermabond solution in that pen, so make sure that you coat it well. But I make certain that I do not press down onto the incisional area, because I do not want Dermabond to get into that incisional area, or you'll prevent the skin from healing. I may or may not have done that before. What we want to do is make sure that that mesh stays somewhat flexible. And now we have a waterproof and basically almost a bomb-proof incision that's well closed, watertight, and we can avoid surgical site infections.
And then do you just leave that, or do you put a dressing over that?
You could absolutely leave it. And so what we do in our facility, though, and a lot of it had to do with our bundles, but we use a silver dressing, and we use Mepilex, but you could use a 4x4. Some patients just don't tolerate looking at their incision. So it's whatever you feel comfortable doing, but certainly it in of itself could be enough.
Right. And so if you do use another like silver type dressing, that typically stays on 5 days, something like that.
Mm-hmm.
And then you tell the patient, take that off, much like a large Band-Aid.
Right.
And then what do you tell them about the Dermabond Perennial? Do you say, well, this stays on until your first year anniversary of your hip, or what do you do with that?
Yeah, I ask them to keep it on for at least 3 weeks. And then I have them, if the edges start to curl up, I have them just trim off those edges. Some patients just prefer to leave it on until it peels off. And if they want to do that, that's fine. I've actually seen little pieces of Dermabond Perennial on at 6 weeks. I think that's fine, but I would say a minimum of 3 weeks for your best outcome.
And so let's say I'm 3 weeks and I don't know, my skin just likes it and it's still stuck down.
Mm-hmm.
Do I run hot water on it, or how do I take a blowtorch? How do you get it off?
Yeah, if it's time to take it off, then you can just use any type of Vaseline or petroleum product. You just coat it onto the Dermabond, or the mesh itself, let it sit there for about 5 minutes, and it'll easily peel off. And I have them start from the top and go down, or the bottom up, so I have them not go side to side with it, but it peels off pretty easily. But again, I let them leave it on as long as they feel like, but a minimum of 3 weeks for me.
And so it is some type of petroleum product
That's
that
right.
you need. Okay.
That's right.
Well, we've talked about preoperative, we've talked about the appropriate x-rays to
Mm-hmm.
get, templating to develop a plan for the operation, optimizing that patient to get the modifiable risk factors under control. Talked about anterior, posterior approach. And so we've hit on a lot of the controversies that surround total hip replacement. But the one thing we haven't talked about is, where do you do the operation? Traditionally, this has always been an operation that's done in an inpatient facility, i.e. a hospital. 40 years ago, they were done only at major universities,
Right.
centers, and now they're done everywhere. But as you and I have seen, COVID kind of pushed us to change the way we do things. So of our patients now be for our new system. So we're doing is outpatient.
Right.
So in your mind, what are the indications for outpatient versus inpatient? You can pick outpatient, inpatient, whichever you prefer.
Well, I think the first thing you have to understand, one thing that will lead you to which direction you're going to go is, do they have good home family support? Do they have the physical capacity to get up and get going? And you'll learn a lot of that through prehab. I think those are your first 2 key questions to ask. And if they have no family support to suggest they're going to go home same day, obviously it's not going to work.
And so that's tough. So you really want a caregiver. It could be, a spouse, a friend, whatever, but
Right.
somebody who's committed to helping you out for 5 to 7 days, something like that.
Yeah, to be around, yeah.
Do you think they need to be there 24 hours a day?
I think they do for the first several days, actually. To get, sometimes the nighttime hours are the scariest hours, the first couple of days that you're home, but after that, I think they usually are very comfortable to be alone. So I don't think that to be there around the clock for 7 days, but definitely the first couple of days.
So a good caregiver situation, whatever
Right.
that looks like,
Right.
they're pretty good shape so they can get up and around, like you say,
Mhm.
not somebody who needs a Hoya lift to get up out of bed.
Right.
Their comorbidities tuned up and they're in
Mhm.
pretty good health.
Mhm.
What would you say are contraindications to having an outpatient procedure?
It's one of which we mentioned, not having good home support. But if you've got comorbidities that would need a little more watchful care, one of the biggest, based off of literature, comorbidities that limit our ability to discharge same day is actually BPH in men. So the postoperative urinary retention can be a real problem. So that's something that you really need to know and understand. And there's a small, short questionnaire that you can ask the patient that'll give you a better idea of whether or not they're actually going to be able to urinate postoperatively. And so that's probably one of the biggest trips that we have with people failing to go home same day.
And so that's something that we actually talk to those patients
We do.
about, particularly men, about, do you have a history of benign prostatic hypertrophy? Do you have to get up multiple times during the night to urinate?
That's right.
And so are there things you can do? Let's say they go, well, I get up once or twice. Are there medications you can give men over 55 that may facilitate that? Even if they're, I mean, I know a lot of our patients are on Flomax and things like that, but let's say they're not and they don't totally recognize that. Are things you can do to encourage men to go to the bathroom?
Yeah, what we have found, this has been based off of literature, that Rapaflow really is a really safe and easy drug to give preoperatively. And we do it in every male patient over the age of 50. And doing that, we've eliminated, with the exception of one patient up to this point, that being a limiting factor of same-day discharge.
Right. And I think the other thing that we've realized is that hydration is really important. I mean, typically we used to tell people, well, don't eat or drink anything. And, 20 years ago, we'd have them donate 2 units of blood for, we'd basically bring in anemic, dehydrated patients and wonder, why aren't they doing better?
Right.
So now we encourage them. How much do you tell them to drink the night before or the few days before?
Yeah, starting at least.
I'm talking about water, not alcohol.
Yeah, alcohol. Well, fun would not be a good idea. Starting 48 hours before, I have them drink 8 ounces of water per day. And then the night of surgery, I actually ask them to drink 1 more bottle of water and or add a Gatorade. So we get electrolytes. Because if we're asking people to drink more water and they haven't been, we don't want to flush out their electrolytes. So we want to make sure that we have a Gatorade on board.
So these people come in well hydrated, kind of all plumped up.
That's right. Yeah, and so we have them continuing to drink fluids right up until the time that they leave their house. And in the greater Seattle area, it usually takes them up to an hour to get to us, and then they're usually in our preoperative area for about 2 hours. So we've got at least somewhere between 3 and 4 hours from the time that they had something to drink.
Okay.
Yeah.
Well, I think we've covered a lot of topics, and we want to leave time to make sure we have room for questions. So why don't we open it up and see what Sandy has cooked up for us here?
Thank you so much, guys.
We're going to hydrate. I think we're both going to have total hips tomorrow.
Thank you guys both so much. That was a wonderful presentation and a beautiful surgery to watch. I am ready to scrub in whenever you guys need me.
Well, I thought you were going to be a patient.
Oh boy, not yet. Give me a couple of years. All right, we have a few questions that came in, so I'm going to go ahead and shoot them off to you guys. The first one is, we have heard that the direct anterior hip approach has increased risk of wound-related issues. Have you seen this in your practice?
Well, I'm going to let our wound care specialists address that.
Yeah, they're definitely, you have to be careful with the direct anterior hip, particularly with your heavier patient that may have a pannus. So number one, preoperatively, make sure you look at everybody's hip. Make sure you know and understand. I can't tell you how many times there's been a little bit of a surprise when I ask them to lift up their pannus and you're like, wow. So that's one more way of optimizing your patient, making sure that they're clean, that we don't have any issues with any type of skin issues there.
Yeah, I think that's very important. I mean, because you want to look under there. Often they'll have just a red kind of chronic fungal infection. And, every once in a while you find like a piece of a sandwich or something in there. So you want to make sure that you have checked that out ahead of time and then encourage them for the month before surgery to be very diligent about washing, drying that area, getting it to dry out. And you don't want to put a whole bunch of foot powder and stuff like that. You want them just to wash it, dry it, air it out, lie on their backs. And then what about while we're positioning these people? Because sometimes, a large pannus can get in the way of actually doing the operation. Any tips on what the nurses can do?
You're right. Yeah, so we literally tape the belly away from the involved tip. And so there's a taping technique that is very safe. You don't cause blistering of the skin or anything like that, but we can pull that tissue up out of the way.
Okay.
And then we try to stay out of the ephemeral crease as much as we possibly can, but we also don't want to tear the tissues there either. So it can be a little bit of a challenge sometimes.
Yeah, I think one of the most commonly uttered words I hear during the early part of an operation, you need to extend your incision. You need to extend your incision. So you always start out optimistic with this little tiny thing, and then I'm getting berated by somebody standing next to me. So I think, making an appropriate length incision, trying to steer clear, if you can, of the inguinal crease, making sure you've done appropriate things preoperatively. You went through a great example of how you close the skin on every case. Are there certain things, if let's say somebody just has a really large pannus or they're on aggressive anticoagulants, that you'll do in addition to the outstanding closure?
Yeah, I do. I'll use the wound vac in those patients. So if I've got an obese patient who we've gotten optimized the best that we can, I will definitely use a wound vac to help heal up that tissue.
And how long does that typically stay on for?
Generally, those stay on for about 7 days.
So I think, Sandy, to address the question, yeah, there can be, and there's been papers published that you can have increased wound complications, particularly in the non-optimized obese patient. But I think with the appropriate types of precautions, you know, you can avoid those things. And we've had very few wound problems with the anterior approach.
I agree, and and we've mentioned this before during the wound closure. So we've eliminated all of the potential things that could cause an infection. We are not using a braided suture. We don't have knots. And so we're using all of the appropriate suture lines. And that's where Ethicon has just done really an amazing job of finding solutions to problems that we've identified.
Right.
Excellent. So next question is, are there any risks of dislocation with a direct anterior approach?
Well, that's a great question. And, you know, with any total hip, there's always a risk of dislocation. So there's no such thing as, oh, I've never had a dislocation. And the only surgeons who can say that are the surgeons who don't follow their patients. But yeah, every hip replacement has the potential risk of a dislocation. The beauty of an anterior approach is the most common dislocation is posterior. You don't touch the posterior capsule with an anterior approach, so you're not taking down the posterior tissue. So the risk of dislocation is substantially less with an anterior approach, because most people dislocate by bending way forward, not following precautions for a posterior approach hip. We just don't have that situation. You can have anterior dislocations, and in certain patients with spinal pelvic conditions where they have a spinal pelvic unit that is stuck either standing or sitting, and that's a whole nother topic that Jan and I would love to talk about, but there's not time for that. But suffice it to say, if you've got a really stiff spine or you've had a prior fusion of the lumbar spine, particularly to the sacrum, you don't have the normal pelvic mobility, so you can have increased risk with dislocation. That's a situation where maybe we'd elect to use a dual mobility cup because we just can't guess which way we should err on the side of. But, you know, our personal dislocation rate with an anterior hip is about 0.4%. Typical nationwide dislocation rate for a posterior approach hip is anywhere from 1% to 2%. So it's dramatically lower. It's not zero, but it's a lot less.
Yeah, and that's another good reason to template, because you'll often see that the spine is fused. You'll see hardware in their spine, or you'll see, based off of the AP pelvis, just the look of it will give you an idea of whether that pelvis is kind of stuck in one position versus the other, so that we would know. That would be a key tip off that we need to use that dual mobility or try to change the position that we're putting the cup in.
Right, right.
Excellent. All right, we had another question come in. It says, you mentioned watertight closure a few times. What's the benefit of the closure being watertight?
Yeah, that's a great question. So what we've done in the past, where we've had wounds that tend to be a little leaky, a little soupy afterwards, is basically if something is coming out, something can and will get in. And that is oftentimes bacteria, because as we all know, we have Staph aureus on our skin. The other thing is if something's draining, we're trying to clean it. Who knows that we have clean hands when we're touching our wounds, because we have some patients who are just pickers, for lack of a better way to describe it. And so getting a watertight closure really does eliminate the conduit for something to get in. And if you've got a nicely dry and clean wound, people tend not to pick at it.
Yeah, I remember several years ago when patients used to stay a day or two in the hospital, and we used to use staples for our wound closure, particularly for total knees. And this gentleman was obviously had gotten a lot of pain medicine. He's sitting there talking to us, and you and I are rounding on him, and his dressing's off, and he's picking his nose and then going, so these staples, and he's kind of flicking at his staple with his finger that was just inside his nose. And I think we both had this aha moment. Maybe we should not use a dressing they can take off, and maybe we shouldn't be using staples, because this doesn't seem like a good situation. So I think the beauty of watertight closure, that even if you're a picker, so to speak, you're not going to be able to pick your way in unless you rip the wound open. So I think there's a bunch of reasons why that makes a whole lot of sense.
Great.
Excellent. And a follow-up question to that is, so how long ago did you start using Perennial? How long ago did you start using Stratifix? And do you have an opinion as to if you had to only choose one, which one would you choose? It's a tough question, I know.
Was that from Rosanna Dana from New York?
I think so.
Well, so we first started using on a very, very consistent basis. 2016 is when we first started rolling out with the Stratifix line. And wow, I tell you what, that is really, really tough. But I think what I would have to say is that I think you can get a really nice watertight closure with your suture line using Stratifix through your fascial, subcutaneous, subcuticular level, and get a pretty nice watertight closure. So if you had to take something from me, that may be that I'll let you have the Dermabond Perennial, but that is really, really hard. Because the other thing I do know is that if you don't get a nice watertight closure, you're almost setting yourself up a little bit for failure of your Dermabond Perennial not working well for you. If you can't control the drainage at the end of the procedure.
I mean, that is really a tough question. I mean, I know you're a student of scripture. It's a little bit like Solomon. Wasn't he the one that was going to cut the kid in half or something? You can have half. Or am I wrong?
Well, no, you're right. Yeah, King Solomon, the women were fighting over the baby. And so he wanted to cut the baby in half. So the mother that had the baby is like, no, you just take the baby. Don't cut my baby in half.
So I think this is like a King Solomon question. If you say, which one would you give up? You really wouldn't want to give up either.
No, I don't. That's why I'm like, no.
So that means you're the mother of Perennial, Dermabond, and Stratifix.
Well, that would be a big claim, but wow.
I like it. And I think at the end of that story, the true mother got to keep the baby. So Jana, you get to keep both Stratifix and Perennial.
Yeah, there you go.
Love it.
Excellent. All right. Next question that came in. Do you have to have a Hannah table to do a direct into your hip approach successfully?
I would say the answer is absolutely no. We do it. We have 4 in our hospital because we have a lot of our partners who do this, but you absolutely can do a really good job with an anterior approach hip without the Hannah table. The reason that we've chosen it is it just facilitates the exposure of the femoral side. Doing the socket is really unchanged, doesn't matter what table you use, but we found it easier to use the Hannah table to expose the proximal or top aspect of the hip where we start putting the broach in and things like that. But there's other ways to do it for sure. And the people who do a quote tableless type of anterior approach doesn't mean they're doing it on the floor. It means they're not using a special table. They're using a standard OR table, and it works very well. So I think it's a little bit like arguing over religion. It's what you're used to, what you've done, and what you've grown accomplished at.
Very good. All right. Next question is, how do you manage your heavier patients with a pannus as it pertains to your incision placement, closure, dressing, etc.? I think you answered that though, correct?
Yeah, I think so. You know, the other thing that I didn't mention was on those patients, what I may also do is take my Dermabond Perennial and take it just a little bit further than a centimeter above my incision to try and give a little extra coverage or protection where the skin is folding over on itself. So that's the only additional thing that I might add to that.
Yeah, I think it is what is. I mean, ideally, I would love to say that we optimize all our patients so well that nobody has a pannus, but that's simply not true. And there are some, and you know, people carry their weight in different ways. You have some men that have a big, thick stomach and not much of a pannus. And then you have some women who have tiny little spindly legs and a very big pannus and everything in between. So I think, you know, you got to be prepared to deal with this. And while their BMI may not be over 40, they could have like pannus that would go along with a BMI of 50 stomach. So it's a matter of being tuned into it, doing the proper pre-op education, cleaning, and then afterwards managing that as well as you can.
I agree.
Excellent. Have you seen any change in your patient satisfaction as you've transitioned to same-day discharge versus next-day discharge? And add on to that question would be any increase in complications?
Well, patient satisfaction, what do you think as far as same day versus next day discharge?
Well, I tell you, it's almost like a surprise. It's like we call them that night and see how they're doing. And we're kind of like, are you okay? Did you die at the bottom of the stairs? I mean, like that was kind of our first response.
Yeah,
But
yeah.
now they're like, this is fantastic. I think they really enjoy getting home. I think they've actually really loved it.
Yeah, I think, initially we were very selective, and then like we mentioned, we're doing over 55% of our patients. I mean, our outpatient facility hasn't even opened yet.
Mhm.
And so we're doing more than half as same day discharge. And I would agree. I mean, you and I call these patients at night, and the first time I thought I'd hear the sound of somebody cartwheeling down the stairs, but they're at home eating dinner, watching TV, and we really haven't had any issues. We most recently had one guy who had a history of BPH and ended up just could not urinate, even though he urinated at the facility twice. They did a bladder scan. It wasn't excessive. And so it looked like all systems were go, but then he got home and couldn't urinate and had to go back to the ER and get catheterized. But he's the first in over several hundred patients that happened to. So I think the combination of appropriate screening, using the tool you talked about, giving Rapaflow to the men over age 55, and just making sure they're well hydrated before surgery is solved that issue. We haven't had people with excess pain. We haven't had people bleeding. Again, it's been a very pleasant surprise. So I think our patient satisfaction is higher because people really do appreciate being home. We haven't seen an increase in complication, readmission, or anything like that. So from that standpoint, I think our experience mirrors the data in the literature that shows there is no difference, complication, et cetera, with same day versus next day discharge. But we also use pretty selective criteria to determine who's going to do that.
I agree. And I think the other key is to have in place the what if scenario. So what if this guy needs to get to the emergency department, and so they're alerted that this may happen, and they have all the things that they need to do to help those patients out. So I think it's just having the safety net up, but we just really haven't had to use it.
Right. I would agree.
Perfect. All right, we have another question that came in. Do you ever see skin reactions when using Perennial? Is there certain patients you choose not to use it on apart from hypersensitivities?
Now, there are a couple patients that I will sometimes opt out of, and the greatest example is we had a lady this week who was 90. I mean, wow, what a firecracker. But her skin was so thin, I could see the needle. If I put the needle underneath the skin, you could see it as plain as day. And in those patients, I worry to add Dermabond Perennial to it that I could cause some increased skin irritation, because we know the skin is going to stretch with swelling. And I think that it's very easy to manage that in a total knee, for example. You want to get that knee maximally flexed to mimic as if that skin is being stretched with swelling before you put your Dermabond Perennial on. A little more of a challenge during the hip. We don't see that much swelling in the hip much anymore, but those were the people that I would sometimes steer away from. And in fact, I would probably go more toward a wound vac if I'm concerned in that type of patient. But we do need to be asking our patients, like, have you had a reaction to any type of surgical glue? Women, have you ever had any issues with having eyelashes put on, or fake nails glued on? So if they have any type of reaction to those things, that would be a patient you want to steer away from. And then there's a subset of patients that are going to have a reaction, which they're going to have it, and you won't know who those people are until it happens. But I think, again, it's all about the preoperative education, letting them know that it could happen, making sure that doing plenty of icing, plenty of elevation to avoid the massive amount of swelling that can occur after surgery, because skin doesn't like to be stretched no matter what your closure strategy is. So I think that you have to be strategic. Not everything fits every person.
What about blistering? Do you see blistering with Perennial Dermabond?
Yeah, we have seen blistering. And again, we have also seen it with staples.
Mm-hmm.
We've seen it in non-surgical things like ankle fractures, for example. We call it fracture blisters. And it literally is a rapid amount of swelling, and the skin does not tolerate being stretched that quickly.
What about latex allergy? Is that a contraindication to Dermabond?
Actually, it's not. I mean, I think this is probably a patient that you could safely use that on.
Okay. All right.
Excellent. Well, it looks like we are right on time here. I want to thank Dr. Barrett and Jana. Thank you guys both so much for such a wonderful presentation and for answering all of our audience's questions. And I want to thank everybody who joined us for today's webinar. We really appreciate you being here with us tonight. Please note you will receive an email later today with a survey. Please complete it to help us make our programs better. We thank you all again so much and hope you have a wonderful rest of your day.
Thank you.